Welcome to the Deep Dive. You've shared your sources on medical surgical nursing, and today we're really zeroing in on the lower urinary tract, the ureters, bladder, urethra.
hmm
It's all about control down there.
Yeah, that's right. It's fundamental.
And our main theme is elimination. But it's fascinating how our sources really connect this to, well, patient dignity, patient autonomy
Mm.
versus the constant risk of things like infection and obstruction.
Exactly. When elimination goes wrong, it's not just inconvenient. It hits those other core concepts: heart think, pain, immunity, definitely tissue integrity.
Okay, so what's the scope today? What are we covering specifically?
So we're sticking to these non-kidney structures you mentioned: ureters, bladder, urethra, and we'll unpack four main conditions: urinary incontinence, or UI,
Okay.
then cystitis and UTIs, which are super common. After that, urolithiasis, kidney stones, basically.
Oh.
Yeah. And finally, urothelial cancer, focusing on the safety aspects there.
Got it. So our mission here is to pull out the key pathophysiology, the essential nursing actions, and importantly, those safety alerts you need for clinical practice.
Right. And before we really jump in, let's get some terms straight. It's easy to mix these up.
Good idea.
Okay, so anuria, that means basically no urine output at all, versus oliguria, which is just scanty, very low output.
Anorexia, oliguria.
Then endysuria, that's the classic pain or burning when someone urinates.
Right.
And this one's critical for safety. Bacteria just means bacteria in the urine. It might not even cause symptoms. But if that infection spreads into the bloodstream, that's bacteremia or urosepsis.
And that's the emergency.
That is a full-blown, life-threatening emergency. Needs immediate action.
Wow. Okay, that really sets the stage. Let's tackle the first big concept then, urinary incontinence, UI.
Yeah.
What's the difference between just, normal control continence and UI?
Well, normal continence is something we learn. It's complex coordination, actually. Your bladder muscle, the detrusor, has to relax nicely to store urine, while the urethral sphincter stays contracted, keeps the gate closed. Then, for elimination, the bladder contracts and the urethra relaxes. It's a coordinated dance.
Okay.
UI is when that control breaks down. It's the involuntary loss of urine, and it has to be severe enough that it's causing, social issues or problems with hygiene.
Right.
And here's the absolute key point I always stress. UI is not a normal part of aging. It's not something you just have to accept after childbirth. It's treatable.
That's a really important mindset shift. So let's break down the types. The sources list four main ones. First up is stress incontinence.
Yeah, that's the most common one, especially in younger women. It's leakage that happens during activities that suddenly increase pressure in the abdomen.
Like laughing or coughing.
Exactly. Laughing, coughing, sneezing, jogging, lifting something heavy. What's happening is the urethra just can't tighten enough to counteract that sudden pressure spike from the bladder.
Okay. Then there's urge incontinence, which is also called overactive bladder, or OAB. This sounds different.
It is different. With urge incontinence, you get this sudden, really strong, gotta go right now feeling.
Mm-hmm.
And then you lose urine, often a large amount, before you can make it to the toilet. The problem here is the detrusor muscle, the bladder muscle itself, contracts involuntarily when it shouldn't. You can't suppress that signal. More common in older women.
Okay, brain-bladder disconnect almost. Now, overflow incontinence, this one seems counterintuitive. It's about not emptying.
Exactly. The detrusor muscle is underactive. It doesn't contract effectively, so the bladder doesn't empty properly. It just keeps filling and filling.
Yeah.
Gets overdistended.
It overflows.
Pretty much. Urine leaks out in small amounts because the pressure inside gets so high. It's like a safety valve to prevent rupture. It's really chronic retention causing leakage.
Fascinating. And the last one is functional incontinence. This is where the urinary tract itself is okay.
That's right. The bladder and urethra are working fine, technically, but the person still loses urine because of other factors.
Like what?
Like severe dementia, where they don't recognize the urge or know what to do, or significant mobility issues, they just can't get to the bathroom in time, or even environmental barriers, like the toilet being too far away or blocked.
So the nursing approach there is totally different.
Completely. You're not focused on bladder retraining, you're focused on modifying the environment, assisting with mobility, or managing the cognitive impairment.
You mentioned older adults. The sources point out a lot of non-urinary risk factors that pile up for them with UI. What are the big ones?
Mobility issues are huge. That urgency to get to the bathroom is a major cause of falls.
Right.
Then neurological conditions, stroke, Parkinson's, things like that, and polypharmacy, taking multiple medications.
How do meds contribute?
Well, diuretics obviously increase urgency. CNS depressants can reduce awareness of the need to void. And anticholinergic drugs, which are really common, can affect both bladder function and cognition. It's a perfect storm sometimes.
Okay. So given UI is treatable, what are the priority nursing interventions, especially non-surgical ones?
Behavior changes are really the first line, the gold standard. And the cornerstone is pelvic muscle exercises, Kegels.
Everyone's heard of Kegels, but doing them right is key. Yeah.
Absolutely. You have to teach the proper technique. It's not just clenching randomly. It's tightening those pelvic floor muscles, holding for a count of 10, then relaxing completely for a count of 10.
10 seconds hold, 10 seconds
Right.
relax.
And do about 15 of those repetitions in a set. And you need to do sets 3 times a day, ideally in different positions, lying down, sitting, and standing.
And it takes time to work.
Oh, yeah. You need to tell patients it can take up to 3 months of consistent daily effort to see the full benefit. It's a commitment.
Okay. And then there are training programs, bladder training and habit training.
Right. They sound similar, but they're for different patients. Bladder training is for people who are alert and motivated. The goal is to consciously suppress the urge to void and gradually increase the time between voids, lengthening that interval.
Got it. And habit training.
Habit training is more for individuals with cognitive impairment. It's caregiver-driven. You don't focus on suppressing the urge, you focus on scheduled toileting, taking them to the toilet on a regular schedule, like every 2 hours, whether they feel the urge or not.
Okay. And this leads to a really important action alert in the source material about using absorbent briefs or pads.
Yes, this is crucial. You cannot effectively do habit training if the approach is just, oh, wear this brief and it's okay if you wet it. That completely undermines the goal.
It becomes containment, not training.
Exactly. The focus has to be on timed toileting. And even when using pads or briefs, and we should use those terms, not diapers, there's still a significant risk of skin breakdown.
You mean incontinence-associated dermatitis, IAD?
Precisely. Even if the pad wicks moisture away, you still have heat, sweat, friction. It creates a perfect environment for IAD. So skincare is paramount, but the goal should always be restoring function or implementing effective timed voiding, not just relying on containment products.
That makes perfect sense, protecting tissue integrity. Okay, let's shift gears from incontinence to infection. Cystitis and urinary tract infections, UTIs.
Right. Cystitis just means inflammation of the bladder. It's usually caused by infection, but not always irritants can do it too. UTIs, though, are infections anywhere in the urinary tract, and they are incredibly common.
How common?
Second only to upper respiratory infections, they're a huge healthcare issue.
And the sources talk about categorizing them, complicated versus uncomplicated.
Yes, that's an important distinction for treatment. An uncomplicated UTI is typically just in the bladder, no underlying structural or functional problems, usually in a healthy, non-pregnant woman.
Okay.
A complicated UTI means there's some other factor involved. Maybe the person is pregnant or male or has diabetes or an obstruction like a stone or enlarged prostate, or they're immunocompromised.
And that changes the treatment.
Significantly. Complicated UTIs often need longer courses of antibiotics, maybe 7 to 21 days, compared to maybe 3 days for uncomplicated, and require much closer monitoring because the risk of spread, like urosepsis, is higher.
What's the usual cause?
Overwhelmingly, it's E. coli bacteria ascending from the person's own bowel or perineal area, over 80% of cases.
And what breaks down our natural defenses against that?
Several things. In women, the urethra is shorter, providing easier access. After menopause, decreased estrogen changes the vaginal pH and flora, making it easier for E. coli to thrive. Using spermicides can also disrupt the normal flora.
And in men.
The big one is an enlarged prostate, which obstructs urine flow and leads to stasis urine. Sitting in the bladder is a great place for bacteria to grow.
Yeah, for anyone.
Diabetes is a major risk factor because the glucose in the urine feeds bacteria. Any kind of obstruction like stones or incomplete bladder emptying allows bacteria to multiply.
So what are the classic symptoms we need to look for?
The classic triad is frequency, having to go often, dysuria, pain or burning, and urgency, that sudden, strong need to go.
But older adults are different.
Often, yes, they might not have those classic symptoms at all. You need to be highly suspicious if an older adult presents with new or worsening incontinence, grossly bloody urine, foul-smelling urine, or, and this is critical, sudden onset confusion or change in mental status.
That confusion piece again.
Yes. Especially if they have other UTI risk factors, sudden confusion should immediately make you think urosepsis. It's a huge red flag.
Which brings us to a major safety issue in hospitals. CUTI, catheter-associated urinary tract infection. The sources really hammer this home.
As they should. COUTIs are a leading cause of healthcare-associated infections, maybe the fourth leading cause. And the risk isn't small. It goes up by about 3% to 10% for every single day that catheter stays in place.
Wow. So prevention is key. What are the absolute must-dos?
It starts with avoiding catheters unless absolutely necessary, but if one is needed, meticulous hand hygiene and strict aseptic technique during insertion. Securing the catheter properly is vital to the upper thigh for women, lower abdomen for men. This prevents movement and urethral friction.
Makes sense.
Keeping the drainage bag below the level of the bladder at all times and never letting it touch the floor. And maybe the most important thing, daily assessment for continued need. Does this patient still really need this catheter today? Get it out as soon as possible.
And using bladder scanners.
Yes. Using portable ultrasound bladder scanners to accurately check for urinary retention can help avoid unnecessary catheterization in the first place. See if they really can't void before putting one in.
Okay, critical safety points there. If a patient does have a UTI and needs antibiotics, what are the key teaching points?
Number 1. Finish the entire prescription, even if symptoms improve after a few days. Stopping early leads to resistance.
Right.
Number 2, if they're given phenoxyperidine, that's a urinary analgesic, just for symptom relief, you must provide that nursing safety priority warning.
Which is?
It will turn their urine reddish-orange. If you don't tell them, they'll think they're bleeding heavily and panic. It just stains the urine. It's harmless but alarming if unexpected.
Good tip. What about the common antibiotic combo? Sulfamethoxazole trimethoprim, often called Bactrim or Septra.
2 absolutely critical points for that one. First, they need to drink a lot of fluid aim for 3 liters a day unless contraindicated. This helps prevent the drug from crystallizing in the kidneys.
Okay, high fluid intake.
Second, and this is a major safety alert, they must stop taking the drug immediately and contact their provider if they develop any kind of skin rash.
Not just a minor rash.
No. This could be the first sign of Stevens-Johnson syndrome, which is a rare but potentially fatal severe allergic reaction affecting the skin and mucous membranes. Early detection and stopping the drug is life-saving.
Wow, that's a crucial piece of teaching. Any non-drug advice?
Fluids, fluids, fluids. General recommendation is 2.2 liters daily for women, 3 liters for men, to help flush the system. The source also mentions cranberry products, juice, or supplements. The idea is they might help prevent bacteria from sticking to the bladder wall.
Does it work?
The evidence is kind of mixed, honestly. Some studies show a benefit, others don't. It probably doesn't hurt for most people, but it's not a substitute for antibiotics if you actually have a UTI.
Okay. So we've talked about incontinence, infection. Let's connect that to obstruction with urolithiasis. Stones was the basic cause.
Stones, or calculi, form when substances in the urine, usually calcium compounds, but also uric acid or others, become too concentrated. They get supersaturated, and then they precipitate out of solution and form solid crystals, which can clump together into stones. And the single biggest factor that promotes this supersaturation.
Let me guess. Dehydration.
You got it. Dehydration is the most common condition associated with stone formation in people who are susceptible, perhaps due to metabolic factors like gout or genetic tendencies like hypercalciuria.
And the main symptom is that infamous pain.
Renal colic. It's often described as the worst pain imaginable. It's typically severe, unbearable flank pain if the stone is high up in the kidney or upper ureter.
Oh, okay.
Or the pain might radiate down towards the abdomen, groin, or genitals if the stone is moving down the ureter. It comes in waves as the ureter tries to push the stone along.
What's the big danger here besides the pain?
Obstruction. If the stone blocks the flow of urine, the ureter can dilate, that's hydrureter, and if it persists, the kidney itself can swell and be damaged. That's hydronephrosis.
And that's serious.
That is an absolute emergency. Prolonged obstruction can lead to permanent kidney damage very quickly. The obstruction must be relieved.
How do they diagnose these stones?
The gold standard now is usually an unenhanced helical CT scan. It's very sensitive for detecting stones, even small ones, and their location. Urinalysis is also key. It can show blood, signs of infection, and the urine pH can give clues about the type of stone.
Like acidic versus alkaline urine.
Exactly. Very acidic urine might suggest uric acid or cystine stones, while alkaline urine is more associated with calcium phosphate or struvite stones. This helps guide prevention later.
How are they managed? Does everyone need surgery?
No, thankfully. Pain management is the first priority, often requiring strong opioids like morphine or hydromorphone during acute colic. Most stones, especially those smaller than 5 millimeters, will actually pass on their own with time, hydration, and maybe some alpha blocker medication like tamsulosin to relax the ureter.
What if they don't pass?
Then we look at interventions. The most common is lithotripsy, specifically extracorporeal shockwave lithotripsy, or SWL.
Shock waves. How does that work?
It uses focused high-energy sound waves from outside the body to break the stone into smaller fragments that can then be passed in the urine.
Are there safety concerns with SWL?
Yes, the patient is positioned carefully, and their heart rhythm is monitored continuously via ECG during the procedure. The shock waves are synchronized to the R wave of the ECG.
Why synchronize with the heartbeat?
To avoid delivering a shock during the vulnerable period of the cardiac cycle, which could potentially trigger an arrhythmia. It's a key safety measure. Also, patients should expect some bruising on their flank afterwards where the waves entered. That's normal.
Okay. And if lithotripsy doesn't work or isn't suitable?
Then there are more invasive options, like putting in a temporary stent to bypass the obstruction, using a scope passed up the ureter, ureteroscopy to grab or laser the stone, or, for large kidney stones, percutaneous nephrolithotomy, going through the skin in the back directly into the kidney to remove the stone.
And prevention. What's the #1 strategy?
Fluids, again. The most important preventive measure for almost all types of stones is high fluid intake. Aiming for 3 liters or more per day helps keep the urine dilute and prevents substances from becoming supersaturated.
Makes sense. Dilution is the solution.
Pretty much. Then, depending on the specific type of stone identified through analysis, dietary changes might be recommended, like limiting purines for uric acid stones, or sometimes sodium and animal protein for calcium stones. Certain medications, like thiazide diuretics, can help some people with high urine calcium.
Okay, that covers stones. Let's touch on the last major condition. Urothelial cancer. This usually means bladder cancer, right?
Yes, most commonly. It arises from the urothelial lining of the urinary tract, but the bladder is the most frequent site. It's often called transitional cell carcinoma, or TCC. A key feature is that it can be multifocal, starting in several places at once, and it has a high tendency to recur after treatment.
What's the biggest risk factor here? We talked about dehydration for stones. What about bladder cancer?
Tobacco use. Smoking is far and away the single greatest risk factor. It's estimated to cause about half of all bladder cancers in men and maybe a third in women.
Wow. Any other risks?
Yes, exposure to certain industrial chemicals, particularly aromatic amines used in processing dyes, rubber, paint, textiles, and leather. Chronic irritation or infection can also play a role.
What's the most common sign that patients should watch for?
The primary cardinal sign is painless hematuria. That means blood in the urine, either visible, gross, or only seen under a microscope, microscopic, that occurs without any associated pain or discomfort.
And it might come and go.
Exactly. It's often intermittent. Someone might see blood once, then it clears up, so they ignore it. That delay in diagnosis is dangerous. Any painless hematuria needs investigation.
Okay. What about treatment? For deeper cancers, the source mentions radical surgery.
Yes. If the cancer has invaded the muscle wall of the bladder, the standard treatment is often a radical cystectomy, which means removal of the entire bladder, plus nearby lymph nodes and associated reproductive organs depending on gender.
If the bladder's removed, how does urine leave the body?
That requires a urinary diversion. Common types include an ileal conduit, where a piece of the ileum is used to create a passageway for urine from the ureters to a stoma on the abdomen, collected in an external pouch. Or sometimes a neobladder can be created internally from bowel tissue, allowing more normal voiding.
And for more superficial cancers, sometimes they use intravesical chemotherapy, putting chemo directly into the bladder.
Right. And one common agent is BCG Bacillus calmette-guerin. It's actually a weakened live bacterium, related to the one that causes tuberculosis, used as immunotherapy to stimulate the body's own defenses against the cancer cells.
Live bacteria, are there special precautions?
Absolutely critical safety precautions. Because the patient is shedding live virus in their urine after treatment, they need strict instructions for 24 hours. Men should sit down to void to prevent splashing. Everyone should avoid sharing toilets as possible, but if they must, the toilet needs to be cleaned with a 10% bleach solution after each use during that 24-hour period. Underwear and clothing exposed to urine should be laundered separately with bleach. It's about protecting household contacts.
That's vital information. Okay, we've covered a lot from managing incontinence behaviorally to spotting UTIs early, handling stone emergencies, and the risks and treatments for cancer.
Yeah, it's a broad spectrum, but it all comes back to that core concept of elimination. We saw how crucial early detection of UI risk is, especially in older adults, to prevent falls and skin breakdown.
Right.
We emphasize CIUTI prevention as a fundamental safety standard in any healthcare setting.
Definitely.
For stones, it's about rapid pain relief and addressing that potentially devastating obstruction.
And recognizing those emergencies.
And we saw clear links between lifestyle and these diseases, dehydration and stones, smoking and bladder cancer. It really highlights the impact of patient choices and exposures.
It really does. Which leads to maybe a final thought for you listening. Given how common UPIs are, the high cost of managing chronic incontinence, the pain of stones, how can we as nurses really push the needle? How can we better use community resources, patient education, things like bladder training or promoting hydration to shift the focus from just treating these problems after they happen towards actively preventing them in the first place?
That proactive approach, that focus on prevention and early intervention, is really where nursing can make a huge difference in urinary health.
Couldn't agree more. Thank you so much for walking us through these sources and sharing your insights on this deep dive.
My pleasure. It's important stuff.
Absolutely. We'll catch you next time.